Inside the human chest, a high-pressure cardiovascular pump beats violently, situated millimeters from two large organs undergoing rapid expansion and contraction. For early anatomists mapping the body, the question was how these moving parts survived. Without separation, mechanical friction and pressure demands would destroy the organs. The solution relies on the rigid boundaries of the thoracic vault. This space is sealed superiorly by the thoracic inlet, enclosed by the ribs, sternum, and spine, and closed off inferiorly by the muscular diaphragm. To prevent interference, this internal vault is strictly compartmentalized into three isolated zones. The two lateral zones are the right and left pleural cavities, engineered exclusively to provide a pressure-regulated environment for lung expansion. The thorax is a highly engineered, compartmentalized system. Here, strict structural boundaries dictate biological survival. Inside a lateral cavity, the internal architecture relies on the continuous, double-layered pleural membrane. The outer layer is the parietal pleura. It anchors to four distinct borders: the costal region along the ribs, the diaphragmatic base, the medial wall of the mediastinum, and the cervical cupola projecting into the neck. The inner layer is the visceral pleura. It folds inward to perfectly cover the lungs, adhering tightly to the underlying tissue. Between these two layers exists a potential space called the pleural cavity proper, containing only a microscopic film of serous fluid. This fluid serves a dual mechanical function. First, it acts as a high-grade lubricant, reducing friction during respiration. Second, it generates significant surface tension. Like wet glass, the membranes slide freely but resist separation. This surface tension maintains constant negative pressure, physically locking the expanding lung to the ribcage. The pleura is a dynamic mechanical coupling device. The lungs themselves have no muscle tissue. They rely entirely on the vacuum seal of the pleural cavity to pull them open. During normal resting breaths, the lungs do not fully inflate to fill the entire cavity, leaving empty pleural recesses. The largest is the costodiaphragmatic recess. Only during deep, maximal inhalation does the expanding lung tissue stretch down to occupy this reserve space. Because this recess is the lowest point in the cavity, gravity makes it clinically vulnerable. If excess fluid accumulates, known as a pleural effusion, or if blood pools to form a hemothorax, it fills this recess first, physically blocking the lung from expanding. A more catastrophic failure occurs if the chest wall is pierced. This allows atmospheric air to rush into the cavity, creating a pneumothorax. The introduction of air instantly breaks the fluid seal. Stripped of the surface tension holding it to the chest wall, the highly elastic tissue violently recoils and collapses inward. Because the thorax is structurally divided, a breach on the right side only depressurizes the right lung. The left pleural cavity remains sealed and completely isolated. This strict isolation provides essential redundancy. The failure of one vacuum system does not result in total respiratory failure. Moving inward from the cavity, the primary organs of respiration display their own structural adaptations. The right lung is larger, divided into superior, middle, and inferior lobes, separated by distinct oblique and horizontal fissures. The left lung is noticeably smaller, composed of only a superior and inferior lobe split by a single oblique fissure. This asymmetry is structurally necessary to accommodate the heart, forming an indentation called the cardiac notch. Inside both lungs, the bronchial tree distributes airflow.
The main trachea splits into primary bronchi, which divide into secondary lobar branches, and then further into tertiary segmental bronchi. This extensive branching terminates at the alveoli. These microscopic air sacs are the actual functional units where gas exchange occurs. Because they manage the body's gas exchange while requiring their own life support, the lungs utilize two distinct circulatory systems. Pulmonary arteries carry deoxygenated blood to the alveoli, while a separate bronchial circulation supplies oxygenated blood directly to the lung tissue. Airflow through these pathways is modulated by the pulmonary plexus. Sympathetic nervous signals induce bronchodilation to widen the airways, while parasympathetic signals trigger bronchoconstriction. Every feature of lung morphology, from its lobes to its blood supply, is shaped by the spatial and physiological demands of the neighboring cardiovascular system. That central cardiovascular zone is the mediastinum, a dense compartment perfectly wedged between the two pleural cavities. The critical landmark used to map this densely packed space is an invisible horizontal plane extending straight back from the sternal angle to the vertebral column. This specific plane divides the central column into the superior and inferior mediastinum. The superior mediastinum acts as a major transit zone, containing the arch of the aorta, superior vena cava, trachea, and esophagus. The larger inferior mediastinum is further subdivided into 3 vertical slices, anterior, middle, and posterior, using the pericardial sac as the dividing boundary. The anterior mediastinum is a shallow space located between the sternum and the pericardium, primarily housing fat and remnants of the thymus gland. The middle mediastinum is the cardiovascular engine room. It holds the pericardium, the heart, the main bronchi, and the massive roots of the great vessels. Behind that, the posterior mediastinum acts as a deep vertical conduit, carrying the descending thoracic aorta, the esophagus, the ischius veins, and the thoracic duct down toward the abdomen. Because this central column is bounded by rigid bone and tightly packed with vital organs, it has zero capacity for expansion. Any tumor, enlarged lymph node, or localized swelling will immediately compress the trachea or esophagus. The mediastinum is a meticulously zoned vertical highway, ensuring that cardiovascular and respiratory structures pass safely between the neck and the abdomen without tangling. When we assemble the full architectural model, the central mediastinum sits flanked by the 2 pressure-sealed pleural cavities. This arrangement presents one final mechanical problem. How do the massive blood vessels and primary bronchi located in the central mediastinum cross over and enter the lungs without breaking the negative pressure vacuum of the pleural cavity? The integration point is a single anatomical gateway, the hilum, also known as the root of the lung. At the hilum, the continuous pleural membrane forms a sleeve around the entering bronchi and vessels like a tight collar. This allows the necessary conduits to penetrate deep into the lung tissue while completely preserving the airtight seal of the surrounding pleural cavity. This route also serves as the main access point for the pulmonary plexus, allowing autonomic nerves to actively regulate airway diameter precisely where the oxygen enters the system. By physically isolating fluctuating respiratory pressures from high-velocity cardiovascular conduits, the compartmentalized architecture of the thorax ensures that the body's 2 most critical systems can operate simultaneously, continuously, and without interference.